Next speaker, Professor Joachim Oertel. He's going to talk about tubular surgery. Please.
Oertel.
Yeah.
Yeah, you have to give me the access to share the screen. I cannot share the screen right now. It says it's not allowed. Now it's allowed. Okay, perfect.
Now it is okay.
Okay. Hmm. I have this new, let me see. Last time I had also problems with sharing the screen with this browser version. So if yeah, now it's there. Okay, do you see my slides?
Not yet.
Yeah.
Yeah, we can see it now.
Yeah.
You see it?
Yes.
Okay, perfect. Good. So actually, I sent also a recorded one, but this is much better now. So yeah, tube guided surgery.
Oertel, you have to enlarge your presentation.
No, I'm in the presentation mode. Not good. Okay. So you don't see my slides.
We can see your slides, but it's not in the presentation mode. We can see your other slides also on the left side.
Okay. So if I go in presentation like this, you don't see? You don't see any difference?
No, there is no difference. We can see your
Not good. Okay.
next slides.
So then you want to play my recorded presentation?
So whatever you want.
The problem is if I go in presentation mode, you don't see it.
No,
So simply make it full screen.
Yeah, just make it full screen, Joachim. That's it.
No, it's not working. I have done hundreds of webinars. Tell me, I go in full screen, but you don't see it. You don't see it, right? I'm now in presentation mode, but you don't see it, right?
no, we don't see it.
I had this recently with this version. It's a brand new PowerPoint version, and this is a new laptop. This is the second time that occurs to me. So I have to check on that.
I think if you click F5, it will work.
No, it's the same one. F5 is the same presentation mode as any other. Doesn't make any difference.
Okay, you may go on this way, or if you want to.
Either we do it like this, or we go for. Let's do it like this. It's not a problem.
Okay.
So this is my disclosure. It's I have support.
Joachim, can you please open your video? We don't see yourself.
Yeah, well, the problem is that I don't see my. If I see like this, I have no slides.
No, he means just open your video so that we can see you.
Okay, hi.
Hi.
So, but then I don't see my slides. You see my slides now? Do you see the slides?
Yeah, we can see the slides.
And you see me?
Yes.
Yeah.
Oh, good. They have a completely different version. Okay, good. Hi. Now let's start. So this is tube guided surgery, and I think it has various advantages. Not that much in discectomy, but when you talk about all lumbar procedures, I think probably tube guided is one of the best options. This is my disclosure, and yeah, I have received support by several companies in the past. I hold patents restored, so might be some bias. You decide. So this is where I'm from. 1 hour drive from Luxembourg and Frankfurt. And this is our department. We focus on MIS and endoscopic procedures. So it's about 20% of our practice. And actually, it's a traditional department of spine procedures. So We have focused a long tradition in spine surgery and spine fusion. When we talk about spine surgery, we talk always about whether we do microscopic or exoscopic is a big discussion now because the exoscopes are cheaper. But today we want to focus on endoscopic procedures. And when we focus on endoscopic procedures, there are basically three principles. It's tube guided. Tube guided is regarded the least minimally invasive, probably because it's frequently done with a tube system and microscopic procedures. Then we have the biportal and the full endoscopic. The full endoscopic is the difference that you have one telescope with an um, uh, integrated working channel, camera channel, and irrigation channel. You see that we will focus on degenerative indications. I will focus all my data I will present are from lumbar spine. And when we talk about endoscopy, I think it's different from many other indications because we use the endoscope as a visualization tool in an indication in spine surgery where it's not natural to use an endoscope. So this is different from urology, from ENT, from brain surgery, because we don't have a preformed cavity. And we have to talk about very good results with microsurgery. So success rate in discectomy, particularly when you look at all the randomized studies, then we have a success rate of about 90% long-term radicular symptom relief. So it's a very high success rate for degenerative disease. And we need sufficient decompression of neural structures. So this is always an issue, at least in our hands, because when you have our case material, there we have old patients, we have an aging population here in our area. So we have a lot of patients who might have a disc, but they also have lumbar canal stenosis with osteophytes and bulging and calcified ligaments. So decompression is an issue. We need sufficient decompression. And then also we need to treat deformity and instability. So about 1/3 of our patients we consider to adding a fusion procedure. So when we talk about 2,000 spine procedures, we do like 600 to 700 fusion procedures out of these 2,000. So it's not that rare that you talk about endoscopic procedures and then you consider additionally deformity and instability as a potential treatment option. So what are the advantages? The advantages are very obvious. We want to have a small, reduced trauma, small approach. And I think the original idea was to have a decreased scarring at the dura. This to some degree is still the case, particularly when you do the transforaminal approach. But what I originally thought when I started the transforaminal technique, that you can do an indirect decompression. So you basically go only in the disc and don't enter the spinal canal. This in most cases doesn't work. So we have still an exposure of the spinal canal and the structures. And then the postoperative MRI, obviously the scarring is not directly related to the decompression procedure. So some patients have a severe contrast enhancement after surgery, although you did a very small opening. And then there are other patients you have basically almost no scarring, although there was an intensive laminectomy performed. So, but the idea was, because you have a very focused, small approach, small opening, this might result in less scarring and less exposure. And we have a significant patient demand. We have less post-op pain. And I think this is the most significant advantage. With many studies have shown that you have a faster reconvalescence after the surgery with the patients. What are the disadvantages? The disadvantages are that the microsurgical techniques are different from the endoscopic techniques. So either you focus on endoscopy and do only endoscopy, or you know have to have a mixture of microscopic, exoscopic, and endoscopic procedures, and then you need quite a caseload to master all the different techniques. So tight selection of surgical candidates is required. This is, you know, even if you extend your indications, this is still the case. I think the most significant limit is the transforaminal approach. And then you have, of course, a prolonged learning curve depending on the technique. It's not only that you have to master the technique. I think the most difficult thing is to make the ideal case selection and then to select the procedure individually, case by case, and choose from your armamentario. So these are the various approaches and techniques available. You see here, this is an old slide of mine. You see in the upper left, it's a Lloyd technique. It's not on the market anymore. One of the very first endoscopic techniques. No bipolar back then, but you know, it was good for extraforaminal disc prolapses. Very small endoscope. Then you see here all the percutaneous endoscopic techniques on the left. You see here the Vogel technique, which is not on the market anymore. And then you see endospine, metrics, EasyGo. Here's a spine tip. And here you see an example of the biportal technique. So many, many different endoscopic systems. So particularly, for example, when you go in a spine conference in India or so, then you have like 20 different companies selling your systems. They are all similar and all different to some degree. So there are many different options. What is in common is there are two basic approaches. The one is the interlaminar or intralaminar or translaminar approach. So it's a posterior, almost paramedian approach. And then you have the transforaminal approach. So these are the two approaches which are available for the lumbar spine. I will now focus on tube-based endoscopic, microendoscopic procedures of the various endoscopic techniques. The example is here in the upper left. This is usually in the presentation mode, a sequence with animation. You see here, this is an example when you work through the tube-guided, tube-based endoscope for discectomy. Why is it called microendoscopic? Actually, the microendoscopic, this term was coined in the beginning when the metric system was the first tube-based system available on the worldwide on the market. So it's a very, very famous system. And the metric system in the beginning had a very poor quality endoscope. And the poor quality endoscope cost all the people, because they saw that sparing the muscle, detaching the muscle tissue from the spinous process causes less postoperative pain. So the transmuscular approach is a good approach. So they use basically the tube with a microscope. And to still preserve the term endoscopy, this was the first thing that we use a microendoscopic approach. So when you go back to the early applications with the metric system, most of the procedures were actually done mainly or partially with a microscope. And so that this term microendoscopic approach was developed. You see here, these are the various advantages, various other techniques I have already pointed out. So what is the big advantage with the tube-based system? The tube-based system, the big advantage is that you really can do this technique with a large tube as well with microsurgery. So when you do, like we do in our practice, about 90% of the spine procedures not endoscopically, so just decompression and fusion. So it's a heavy caseload of fractures, of osteoporotic patients, of instability, and so on. Then you see that the big advantage is that you can master your technique, and you can apply basically your technique with a minimally invasive approach. So positioning is the same like in microsurgery. Level determination is almost the same. There's some peculiarities which already make it important to have the ideal approach calculation, but it's more or less very similar. Then skin incision is very similar. We go a little bit lateral. We don't go medial in the center. We go lateral because we want to do a transmuscular approach and dissection of fascia. And I think this is also very important to have a transmuscular approach when you want to do contralateral decompression. There was a question in the discussion about contralateral decompression, and I have a video later on the endoscopic spinal canal stenosis procedure. When you see that as far as more lateral you go, the easier it is to do the undercutting. The good thing is that with this tube-based system, we have bimanual surgical techniques available. It's under air, so it's basically a microsurgical technique. Technique is a little bit different. So Carrison punch, you need to do more drilling because you go more straight to the area of maximum compression. You don't have the technique like in a microsurgical case where you come from the non-compressed part, go to the compressed part, and do step-by-step the decompression, and you have limits in your bimanual technique with traction, counter traction, but still it's possible. Yeah, well, this is one of the critics. It can be done with a microscope. That's to some degrees true. You see, this is also animated part, but the smaller and smaller the tubes you use, the more exclusive you can perform these procedures only with an endoscope. So just to show you the size of this is the skin incision. It's about 1 centimeter skin incision where we perform these tube-based procedures. And this is not possible to perform this, at least not, I cannot do it with a microscope because you just have no corridor. You just have no space to look at your through the tube. So you need the endoscope at the tip in the target area. So what are other peculiarities? I think bone removal is very, very easy. So it's very important to have all these options, particularly in our hands. The spinal canal stenosis with bone removal is the most frequent spine procedure now. It's not the discectomy. We have some discectomies, but the most frequent indication now in our aging population is the spinal canal stenosis in the elderly patient. So bone removal is always an issue, and it's much easier, in my opinion, with a tube-based discectomy than with a full endoscopic system. Treatment of complications like dural tears, etc., is almost always possible without switching to a microsurgical opening. And you can add MIS screws and cages if indicated. So this is not part of my talk today, but we have done a lot of endoscopic TLIFs now, where we do the endoscopic decompression, do under endoscopic view, put in the cage, and then do the MIS fusion through the same skin incision. So we can do a two-level, two segments, so 3 vertebral body fusion. So let's see, L3 to L5 with 6 screws through a skin incision of about 2.8 centimeters now. Single skin incision in the and then we do one side after the other. So this is a big advantage with the tube-based system because you can apply huge cages and both sides with screws through this one skin incision. Switch to microsurgery is easy. So if you have to, you can just switch, and I will give you the data, what we have, how often we did the switching. It's not a big difference. You just have to enlarge the incision. Sometimes you have to use a particular retractor or a larger tube, and then you can continue. So it's basically a combination of microsurgical technique with a bimanual traction and counter traction under endoscopic view. So how does this look? What does it look like? I can give you maybe a large example here of the discectomy. You see, this is a patient here with a migrated L4, L5 left side. And I will start it again. You see here, this is the medial, this is lateral, this is a caudal, this is a cranial. So this is the opening. The black is a suction device. Suction device is about 2.4 mm diameter. So the opening here of the spinal canal might be 4 by 5 millimeters or something. So very, very small focused opening. And you see here, this is a thecal sac, and you just see the exiting nerve root. So the disc here, the sequester disc, is just on the shoulder of the L5 nerve root. You see here's the nerve root now. Here you see the nerve root, the decompressed nerve root nicely. So it's a very small focused opening with this technique. And so the older opening of the spinal canal is maybe 4 by 5 millimeters, 4 by 6 we have, and it's a transmuscular approach. So this is what we have done, taken out. This is the sequester disc, and this is the skin incision. Is about, maybe 12 millimeters length. So we talk about lumbar canal stenosis. You see here, this is a typical centric lumbar canal stenosis, and this is the video. And you see here, this is the ipsilateral decompression, and this is already the contralateral decompression. And I always like to point this out. So the contralateral decompression, I think for the contralateral decompression, mandatory is a good drill. It's not only carries and punch, but you need a drill because the length of the bone structure you have to remove is long. So you have to make a small impression with a diamond burr, and then step-by-step decompression. You see here that this is done until we have the contralateral thecal sac completely decompressed. And this is actually, when we do the cadaver courses, this is in many cases, this is the first area where they reach the spinal canal, because all the, when you start with these procedures, the tendency is that you start point too much contralateral than ipsilateral. You see here, this is the postoperative CAT scan. You see that the ipsilateral, there's maybe 1/3 of the facet is taken, and the contralateral, and nicely the bone removed and is decompressed. Another option, what is possible, is a synovial cyst. You see here, this is a typical synovial cyst with a huge impression on the spinal canal on the right side. And here, this is the video. And this is, I think, one of the big advantages, which is different from mainly the full endoscopic technique, because here you can use the application, the traction and counter traction, and you really take out the cyst membranes and the cyst wall. And here orientation is cranial caudal. This is lateral. This is this midline ipsilateral. So we see here the exiting nerve root. This is just here the shoulder of the nerve root L5, and this is here now the exiting nerve root here decompressed. So this is what it looks like in the post-op MRI, and this is again done through a skin incision like this. This is about maybe 12 millimeters. So what are the results in discectomy? These are the lumbar tube-based endoscopic discectomy procedures. We have a long-term, so long-term means a follow-up of 1 year or more. It's 88% success rate with respect to radicular pain. Immediate pain relief is higher, but of course there are some patients, who get again pain or reprolapses. The improvement of motor strength is very high. We had in the discectomy series no root injuries, no complications, no infection, no post-operative neurological deficits. We have 1% CSF leaks in discectomy. In discectomy, treatment of CSF leaks is almost always possible with the endoscopic system. So there's a paper on that in the European Spine Journal. The average time we needed to treat these CSF leaks endoscopically is 2 minutes 40 seconds. So we do a double layer dural plasty. So with autologous fat or muscle tissue, fibrin coated, thrombin coated gel foam sponge, so a taco seal, and then another layer of fat. We had 4 switches to microsurgery in this series now since 2006. So it's 20-year series. 2, we were not able to gain access to the prolapse. So in median disc prolapse, sometimes it might better to do a transfemoral approach. So this is one of our indications for transfemoral approaches. We had 1 switch to microsurgery for technical reason. There was just no sterile telescope available because of telescope breakage. And there was 1 switch for closure of dural tear, where we had a dural tear in the beginning of the procedure. Reprolapse rate is 2.4% at 1-year follow-up, and 2.4 were unsatisfied for other reasons. But I said that this is the lumbar discectomy procedures. Of course, there are other indications, so like synovial cyst or cervical, where we had more dural tears than in the series. So when we compare the spine endoscopy, and we have to be better than, or at least comparable with microsurgery, which is still the gold standard. The advantage of the tube-guided endoscopy is it's very similar to microscopy, so it's under air. The bimanual tissue separation is possible. We have, of course, with every new technique, you have a learning curve, but the advantage is that the learning curve is short and steep, and you can taper your learning curve. You can start with a large tube, start with microscopic surgery, and then go smaller and smaller the more experienced you become. So you don't have to abandon the technique that frequently as you might have to do in other techniques. Bone removal is easy, particularly if you use a diamond burr. Why diamond burr? There are 2 advantages. One is that we have no injury to dural structures as long as we use irrigation. There's a big advantage. And another big advantage is it vaporizes the bone. So you have not much dust. You don't have to suck it away. It's just gone. So it's a big advantage for if you have to do an extensive bone removal work. Treatment of complications is possible. I don't say that you have to do that. I mean, but it's possible. So the most important thing is usually the success, the result of the patient. So if you feel more comfortable to switch after dural tear, just switch. I would not hesitate that much as we did in the beginning. Switch to microsurgery is easy. Sometimes you have to, adjust your retractors, but basically you can just open up and use this. So in comparison with the other techniques, I think biportal is very similar. The handling is a little bit more difficult underwater, and I personally have a problem when you have like complications like dural tears and everything. I think it's easier to treat this within under air condition. Otherwise, it's quite similar. The big difference between tube guided and biportal is that the biportal has a better angulation for bimanual technique. This is a big advantage. The disadvantage is that you have actually more transmuscular manipulation. So actually the manipulation to the muscle, to the area of the muscle tissue is much larger than in the tube-guided case. So, but still it's quite similar, a little bit different since you have it underwater and irrigation. Full endoscopy is very different. Full endoscopy, we have not the counter-traction possibility to separate the tissues. So I think learning curve is long. Bone removal is possible, but you would never think, in my opinion, think about a full endoscopic approach to a 3-level lumbar canal stenosis. At least not in my hands. I don't. This is not what I expect because this is very time consuming. Then treatment of complications is difficult. If you do that, if you want to do it, then it's much more difficult. If you think There is always a discussion in the German Spine Society if you have to close a suture your dural tear, then this is very difficult with the full endoscopic. And the switch to microsurgery is difficult because it's a completely different approach. So when we conclude, let me see, endoscopy is it represents a very good option in any obstruction of spinal canal in the tube-based system. Intraoperatively, it's easy to handle, a steep learning curve. Bony work, treatment of complications, and addition of fusion technique is possible. I have not shown this today because I think it's too time-consuming, but it's a surgical technique of choice for us. And if you're interested, this is the World Spine with us, and just apply, send your abstracts, and it's going to be early September. Yeah, thank you for your attention. You're still there?
Thank you, Professor.
Oertel, thank you so much.
Let's see questions, if any.
All tired now.
Yeah.
Joachim, you didn't mention the cost of the baseline cost of the instruments for biportal or uniportal or tube guided. How do you think about this?
The cost of, yeah, the
of
cost
basic instruments.
This is the cheapest one, in my opinion, is biportal. Because biportal, you can use a lot of instruments you just use for the microscopic procedure. Then for the tube-based, you need scopes which last quite long. I mean, I can say that because we had the medical device regulation of the European Union. So this came into action in directly after COVID-21. And since 21 until 1 year ago, we had no replacement of any endoscopes. And we still did our endoscopic spine procedures. So they last quite long. The most expensive one is the full endoscopic. The full endoscopic, I think it's also the one with the most significant advantage. If your case selection is good, this is a perfect procedure. You know, we do sometimes these procedures in 7-8 minutes. It's just fantastic. But we have a very tight selection of candidates. So all this idea of a transforaminal, decompression of central canal stenosis and so on, I'm not convinced that this is the right thing. So the cheapest one is biportal. Then the tube base is also quite cheap because the tubes they last forever. And the most expensive one is the full endoscopic, regardless of the brand of the system.
But Joachim, if you use microscope from tube, then you don't need an endoscope. So then only the tube system and table mounted retractor system. So this is cheaper probably than biportal.
This is probably cheaper than any technique because you don't need the expensive thing with the endoscope is the tower, which is usually available, and the scopes.
Right.
If you don't need a telescope, of course you're cheaper. Yeah. But then you have to discuss that you need a microscope.
Yeah. So microscopes are everywhere.
Yeah, but to be honest, I think I'm quite disappointed. I'm not consultant for stores anymore. But you remember the 3D HD VTOM system, which was about 30,000 euros. It was a good system, and it's at least in Germany not on the market anymore. I don't understand, because if I started a private practice, I would get that system. Now the exoscope, the R-tip from stores is 350,000. I will not buy a 350,000 exoscope or a 500,000 microscope if I'm in private practice and I have to cover my expenses. So I think that would be a good option, but it's not endoscope. It's true.
Yeah, right. Thank you.
Yeah. Some questions from Sajid Ahmad. How to wave tube guides versus biportal in terms of tissue trauma, incision size, and post-op pain?
Well, there's no, to my knowledge, there's no randomized study.
Yeah.
It's also difficult because I think that when you master one technique, you probably don't need the other technique, right? It depends always on your own indication and your own practice. I tried biportal now in particularly abroad several times because there were the things systems available. I think it's a good system, but still there's probably just a subtle difference. And if you do tube based, and you're used to that, you have done 500, it's probably not that much difference. And this is exactly the same vice versa. So if you do biportal and you have 500 cases and you have very good results, probably it's not big difference to do tube based now. This is different from full endoscopic. Full endoscopic and the right dissection, right indication, that makes a difference. It's fast, but it's really case selection. So in our hands, I think it's less than 10% we do full endoscopic. Less, maybe 5%. I have no data. Very few. Then it's perfect, but it depends on your case selection.
Yeah. Another question from the same our participants. Which one is the better options, tubular or biportal or full endoscopic? Also, your approach for central and calcified disc.
Well, as I said, if you have a median disc prolapse, very median, then I think transfemoral has an advantage. So it's just a principle of approach, is less a principle of technique. Because when you come transfemoral, you just bypass the tickle sac easily. Calcified means that you have to do a lot of bone work. And I think then, in my opinion, it's tube-based or biportal because it's just the drilling you need then. It's the full endoscopic. I've been to so many meetings, and there's always people who say, I do the full endoscopic spinal canal stenosis in 30 minutes. Let me say it this way: I've attended so many cases in the theater. In the theater, I've never seen it. It's just slower, but we have to be honest. I mean, it's good if you have time, and if you're patient, fine. But if you do like 2-3 theaters simultaneously, and you cannot just spend with one case a whole day.
Yeah. Thank you.
No questions?
Uh,
We're overdue, huh? We're 30 minutes late. It's good. It's always like this.
There are some more questions.
Yeah, ask them.
Farukh?
let me. Oh yeah. Oh yeah. Yeah. The same our participants. Just of course about which one is better for spinal stenosis. His question.
Well, the best technique is always the technique you are most familiar with. If you want to do something, And to start, then you just have to, you have to also look for your own cases. What is your case material in your particular situation? So in Asia, they have a young patient population, frequently mainly soft discs. I think then it's good. And then you might treat, if you just have 10% stenosis, you might treat them as well in the full endoscopic technique. But if it's, you have a lot of elderly patients, but primarily single level stenosis, you might think about biportal. If you have a lot of patients where you have to add fusion, where you need all the options, I would probably go for a tube-based procedure. It depends on your own cases. Basically, you can treat everything with all the techniques. If you want to use the one skin incision for everything, so for TLIF, from this simple sequesterectomy up to TLIF, then it's only possible, in my opinion, with a tube-based system.
And Abdul Farukh, there is a comment from Vehbi Gülmen from Turkey. You may say it.
So Vehbi Gülmen, his comments about the tube-assisted discectomy, 3 surgical instruments can be used, and I think this is the biggest advantages of the tube-assisted surgery. And also he said dural tear can be repaired via tube if you have a bayonet designed microneedle holder. Yeah, Professor, your comments about that?
You can use almost all instruments, not all, it depends a little bit, but basically almost all instruments. But this is as well true for the biportal technique. In the biportal technique, you can as well almost all instrument you use for microdiscectomy. Treatment of dural tears, I personally struggle in biportal but it's not that you don't have the options. It's just that irrigation it makes it more difficult, in my opinion. I think under air is easier. Maybe you're more used to that, but I have not extensive practice. So I think treatment of complications is maybe a little bit easier with a tube-based system. And you can, as I said, we have published a series of a couple of cases without suturing at all. Dural tears.
Yes. Thank you.
Farukh, Dr. Sajjad is asking for stenosis cases. Which one is better option? My comment on this is the best way is the tube-guided surgery. Why? Many reasons. One of them is that drilling is easier. Second, drill bits are cheaper. And the complication avoidance are better. If there is a dural tear, you can repair it easily, but in other options, it's not that much easy.
Yes.
So Zilali, I think we have finished. There is no other questions. I think we have
Maybe Onur, we can ask previous speakers to comment on what was told by the other 2 speakers.
Yes. Is Hikmetullah here?
I am here, Ugurpan.
Yeah.
I totally agree with everyone. I think it would be more about how much you can do with your own technique rather than which technique is better. I think it's always, different tools match different hands. So I think getting everything up all together is really helpful in treating our patients. I think it's more of just understanding each other's techniques rather than saying which is better and which is right. I really think it was a really precious conversation.
Hikmetullah,
Yeah, what is the focus of the question? If we talk about the disc herniation, lumbar disc herniation, it depends to your experience and your goal. For example, for lumbar disc herniation, I didn't need any another system. Of course, we can discuss about the stenosis or another type pathologies. So, in my opinion, all three system is minimally invasive. But again, in my opinion, full endoscopic surgery for lumbar disc herniation is most precise and effective method. But any surgeon, if he is doing microsurgery only and results very good, there is no problem. Best method, in my opinion, the surgeon more experienced method. So, but as an old-fashioned surgeon, I recommend that the young surgeons really they should learn the full endoscopic surgery. That is my idea.
Oertel.
I think that's a very good comment, Hikmet. This is a good point because I think the most obvious difference is if you do full endoscopic. Really, you go in, you go out, and you're done. But uh, I think you really need good selection of candidates. So also, in bony cases it's more difficult, but I think you have to have this in your armamentarium because it's a big difference. It's a very different, and also it's a different technique. It's really not that you can use this technique, you know because you have never done it, and then start with it, then you will miss some instruments. So you need some practice. It's very different from biportal or and it's tube based, because basically these techniques you will be able to perform to some degree even if you do them rarely. But full endoscopic is a different technique. So and I think it has definite advantages if you select the patients. So I think this you should know.
I want to
Very
say,
good comment.
Dr. Oertel, I am not agree with you. I am not, if we are talking about the only lumbar disc herniations, I am not selecting the case. I am selecting the method, technique, interlaminar or transforaminal. Okay? But of course, if there is another type pathology, we can discuss about it. Today we are talking about the lumbar disc herniations. And for lumbar disc herniations, I didn't need another technique. Okay, of course, if you have serious complication, for example, big dural rupture, of course you need the microsurgery and you turn the microsurgery. I think that the full endoscopic surgery, again, I am repeating, I am talking only about lumbar disc herniations. If you are doing full endoscopic surgery, most of the cases, maybe 95%, 99%, you didn't need another technique. It depends your technical ability, your experience, also your experience. But every time I am saying that all three type all three technique are minimally invasive. Important one is, okay, all techniques are minimally invasive. It depends to your choice. Also, there is another thing. In these type meetings, always talking about the complication rate is it is more than easy, blah blah blah. If you look the literature and if you investigate the meta-analysis, for the disc herniation, there is no high level evidence. Our evidence only is moderate. If we divide into 5 groups, 3 or 5 level. Do you understand? Also, there are a lot of technical heterogeneity. We are not able to compare very it with confidence to all techniques. So, for these reasons, I am saying that if you are doing tube guided surgery, That's okay. If you are doing biportal or full endoscopy is okay. In my opinion, which technique is better is a wrong question. If you are doing macrosurgery, do it. There is no problem. That's my ideas.
Yeah, the thing is, when is it a disc prolapse and when is it a spinal canal stenosis? This is already a question which is sometimes not easy to answer. We had this discussion when we recently did a paper on
We can discuss another.
discectomy or not in sequestered disc. And then there was one where there's a lot this discussion with the reviewers that they thought that this is lumbar canal stenosis. So it's not that easy. And the case, the inclusion criteria in all the studies is quite different. It's not easy. And well, good.
So we were talking for 2 hours. Everyone has said their own opinion. There are 3 different techniques, and I think the conclusion part is everyone has to do the thing that they can do the best.
Yeah.
So I want to give the words to Mehmet Sileli to make the closure and the last comments.
Yeah. Thank you. Really, it was very, very good discussive webinar. But behind this, why did we get too much interest for this webinar? Why many young surgeons want to use MIS techniques, especially endoscopic techniques. They are very eager to learn this. And patient demands are controlling our techniques. Sorry for saying this, but patients demanding that. And we could not find a very significant advantages of any technique to others. And we must also think about the baseline cost of the instruments and learning time to decide which technique should be used. Thank you for all the speakers and moderators for being with us and giving very nice lectures. Thank you.
Thank you. Thank
Bye
you.
bye. See you in today's, guys. See you.
Thank
In
you.
the simple spine
Goodbye.
muscle. Thank you.
We're waiting you.
Yeah, thank you.